Thank you for your ongoing support every week to run these successful meetings. Over to you, Graham.
Thanks very much, Wendy. So welcome everybody to this week's ECHO webinar hosted by the UCT Department of Medicine. We've got two main speakers this afternoon, and the focus is on the medium to long-term consequences of COVID, both looking at it from the angle of the physical manifestations, the effect on organ systems, as well as the psychological sequelae that some patients who've had COVID-19 suffer after recovering from the acute illness. But before that, we're going to have our regular update from Marianne Davies at the Department of Health and the UCT School of Public Health on the situation in the Western Cape with respect to the epidemiology of COVID-19. So thanks very much, Marianne.
Thanks again, Graham, and to the webinar team for inviting us. I'll keep it short this week, given that we have two talks, and I think the news is bleak, so we'll keep it fairly short. So this is our standard graph of the metrics that we follow: the admissions in blue, deaths in red, cases, the grey bars in the background, proportion positive in yellow, and the utilization in green. And you can see, certainly compared to a week ago, a clear increase in all of those metrics. On the right hand side, just to give a bit of perspective, I've shown the increases since our nadir, which was pretty much at the end of September, almost coinciding with the start of level 1 restrictions. So a 4-fold increase in new admissions, a 7-fold increase in cases, and a 3-fold increase in reported deaths. And I saw today that we had 30 deaths reported today. That doesn't mean they all happened in the last 24 hours, but we certainly haven't seen that kind of number for quite a while. Just in the last week, about a 45% increase in the 7-day moving average of cases. We can go to the next slide. This is looking at testing. You can see there has been a steady increase in testing numbers, and we're approaching the number of tests we were doing during the first peak, and also a clear increase in proportion positive, which is now quite substantially higher in public sector than private sector. And last week it was sort of hitting 20% in public sector and is now well above 20%, 25%. And again, approaching the levels that we had at the peak of our first wave. And you can also see the consequent increase in healthcare workers. We can go to the next slide. This is, if we can go back for a second. Oh, no, this is correct. Sorry. This is just a more granular look at hospitalization separated into public and private sector. We can see increases in both, and we're starting to see the increase in ICU admissions, uptick both private and public sector, very marked increase in the last 3 weeks, which I'm sure anyone here who is working on the clinical platform can attest to. And that very small increase in ICU translates into quite substantial increases on the ground, as I'm sure you can all attest to. Next slide. This is looking at cases in the metro, and really just to illustrate that we're seeing substantial increases across every sub-district in the metro. Mitchell's Plain seemed to have a particularly high increase in the last week, but really it's everywhere. And obviously, the percentage increases are bigger in the places that started smaller. So we tend to see not as big increases in some places, but the actual case numbers, because the axes can be a little bit different, are still quite large. And if you go to the next slide, that's illustrated even more clearly when we look at rural. So we've seen a slightly smaller increase in garden route in the last week, only a 30% increase, but you can see that access is an order of magnitude different to the rest of them. But in terms of the rest of the province outside of the metro, we are seeing increases now in all districts except perhaps for West Coast. And what's interesting from the anecdotal report from the different districts is that quite a few of these are people who travel to the garden route for various different events. So there does seem to be spread through a mix of travel and social gatherings of various forms across the province. Overall, nearly 750% increases are Nadir. In terms of the reproductive number, a week ago we were sitting at 1.35. There are obviously confidence intervals around that, but it certainly hasn't decreased. And we now have, although the deaths tend to be very wobbly because of lumpiness in reporting, that number is converging for cases, admissions, and death, which is reassuring in terms of its validity, although not obviously in terms of spread. And then our wastewater is saying the same thing. We've got the maps for the Cape Town Metro for the last 3 weeks. The largest one is the most recent week. And just to highlight that they've actually changed the scale. So that upper category was above 750 in the 2 left-hand graphs, but it's now above 3,000. So in other words, lighter shades of blue in the most recent map indicate more SARS-CoV-2 in the wastewater, and you can see on the right-hand side for at least 16 of the 24 treatment plants that we're testing, we've seen quite substantial increases in the last week. Go to the next slide. And our standard MRC report, this is last week's report. I've just literally a minute before this started received this week's report, which is not available online yet. In terms of the Western Cape, we've seen a small further increase, but we're still not breaching the upper limit of expected deaths, either for the Western Cape and for Cape Town. The South African deaths nationally remain just above the upper limit of expected. Nelson Mandela Bay has seen a slight slowing in weekly deaths compared to the very steep increases that we had seen, but still a further increase, even though it's a little bit less steep. And we're now seeing very steep increases in Buffalo City as well in the Eastern Cape. One of the questions I was asked last week is whether there's been a change in the probability of mortality in admitted patients comparing the first wave to the second wave, because I think that's been a big feature, particularly in the Northern Hemisphere outbreaks. So the blue line here is showing the probability of mortality in admitted public sector patients week on week, and this is death by 30 days since diagnosis. And I've broken it into 3 periods, those admitted before the 6th of June, those admitted during the second part of our first wave, and then our more recent period. And essentially, I think I did present earlier in this meeting that we did see a drop during the second part of our first wave, despite the fact that the number of admissions actually continued to increase, shown in the orange dashed line, and our proportion diabetic and proportion over 60 also continued to increase beyond our peak in mortality. But if we compare the most recent weeks, and it's obviously early days and those confidence intervals around the absolute mortality estimates are wide, we haven't seen really any change from the end of our first wave, although there's a slight trend towards, certainly in terms of the crude mortality, possibly a slight increase compared to our nadir values. If we go to the next slide. So this is just to kind of think about what's going on at the moment, and the values here are entirely illustrative, but just probably what's in everybody's heads at the moment, but a nice representation that Andrew did to put it into a graphic. So essentially what we're looking at is the fairly standard graph of R0 versus the proportion of the population infected, and the blue line really shows what our herd immunity threshold needs to be for different values of R0. And so the thinking is that in the context of the restrictions that were in place during our first wave, we were able to achieve curtailment of our epidemic for a given the R0 that was in place at the time and at a certain proportion of the population being infected. We don't know exactly what that proportion is. If we had the same age-specific infection fatality rate as the global experience, that's illustrated on the left-hand side, and we would estimate that over 30% of our population has already been infected. And on the right-hand side, if we had a higher infection fatality rate for age, which is possible because of our comorbidity burden and different access to healthcare, then we would actually have had a lower proportion of the population infected. And so what that would mean is that during the second wave, we, as R0 has gone up, as we've relaxed our NPIs, we will have to reach, in the context of this higher R0, a greater proportion of the population before we can curtail. And obviously, if fewer people have been infected so far, that proportion is going to be, the numbers are going to be higher with the associated consequent admissions and deaths. And then we've also included a possible further increase in R0 when we reach winter of next year. So just to get a sense of where we might be at and what we might be seeing at the moment. And obviously, if we could reduce that R0 with further restrictions, which seem to have hit the news today, then we might be able to curtail at a slightly lower value for this current wave. And I'll leave it there. Thanks very much.
Good. Thanks, Marianne, once again for the update and bring us right up to speed with what's happening. So to move on to our two main talks, as the COVID-19 epidemic has evolved globally, it's come to our awareness that this is not just about the acute COVID-19 illness, that a substantial proportion of people have effects that last beyond the acute illness. And in some of those people, the effects can be disabling. And really the term long COVID is now something that's not just in the known about in the medical world, but the lay public are also aware of that. And I've asked Sipho Dlamini if he would address this topic this afternoon. Sipho is an associate professor and infectious diseases specialist in the Division of Infectious Diseases and HIV Medicine at Hoare and at UCT. His particular interests are in HIV and TB, vaccination in adults living with HIV infection, and immune-mediated drug hypersensitivity reactions in people with HIV and TB. Sipho has been working in the COVID service at Hoare for the last 8 months or so, and is very well placed to address this topic. So thanks very much, Sipho, and over to you.
Thank you, Graham, and good afternoon, colleagues. Thanks once again to the organizers for asking me to speak on this topic. I think it's an important topic from a public health perspective. And I think as we are 12 months into this infection, we are still learning more about it. And I just start off by just highlighting one of the things that we always display in terms of when it comes to COVID-19. We often place a lot of emphasis on people who have died, and our stats reflect that, and also people who have recovered. But there's been very little recognition of those who have these persisting symptoms, which are often often affect patients who have had COVID. Some people have been hospitalized, and some who haven't been hospitalized. And certainly try to convince you this afternoon that there's probably a need to document who these people are, and certainly put systems in place to address some of the needs that they may have. So all across the world, if you just look at the stats, we talk about people who have tested positive, those who have died, hospitalized, and then even when we talk about those who have recovered, we often talk about people who have either tested negative or who have just been discharged from hospital, and that in itself has caused some issues. But just to remind this audience is that certainly in the last 10 months, we've begun to realize a lot about this virus. Certainly understood to some degree its modes of transmission. Certainly understood the organs which are affected. Initially, there was a concerted effort in understanding the respiratory disease and its impact, but certainly quickly realized that the respiratory system or organ was not the only organ that this virus could affect, and other organs are affected. Again, there's a variability of sort of the main manifestation of the disease, but primarily affecting the lungs. In terms of understanding the inflammatory pathway, we have certainly come a long way since the early days, and some of that has led to trials trying to target different pathways of the inflammation that this virus may induce, or trying to cripple the virus itself. Some have been successful, some haven't been. But what is still missing is the understanding of the impact of this virus on, and the long-term impact of this virus on the different organ systems. So I think we are at the point where we understand that many organs can be affected by the virus. And certainly there's been an abundance of literature describing the impact, certainly the acute impact of the disease, but less and only now a growing body of evidence about the long-term consequences of COVID-19 on various organ systems in the body. So, you know, by the middle of sort of the year, there was already a recognition of this, chronic symptoms in people who have had COVID, and certainly a growing number of people having chronic symptoms after hospitalization for COVID-19. And one of the issues has been in terms of how do we term people who are having chronic symptoms of COVID, and one of the terms that have come out is long COVID or COVID long haulers. There's still some discussion about whether this is the correct term, and whether or not we should be labeling these patients as, for example, chronic COVID syndrome. Just recognizing that there are a number of infections where chronicity we kind of define and in terms of the duration, and also saying that if you've got chronic symptoms, beyond a particular extended period, 3 weeks for many illnesses, you're then given chronic chronic hepatitis B, for example, or chronic gastrointestinal disease. So the term long COVID is what we've kind of adopted to describe patients who are experiencing chronic symptoms relating to COVID. But just understand that some of these people may have not been tested for COVID before because of the capacity to test, and not necessarily presenting to health facilities when they had their COVID infection, because either they had mild disease and therefore isolated and not tested. So the literature is growing in terms of the recognition of patients having chronic symptoms related to COVID. I must say that there's still no international consensus really in terms of the definition, but the current framework sort of defines long COVID as people experiencing symptoms for more than 28 days, and that's the current working definition. Of course, as we begin to understand more about the condition, certainly I think the definition is really going to change. What's also probably not helping in terms of the clear understanding of this condition is what we define as recovery from your first episode of COVID. As I have just laid out to you, there are people who obviously get admitted for COVID and then get discharged, but aren't discharged from hospital, never fully recover, and may experience a variety of symptoms, in their recovery period or post the recovery period, and these may last for quite a long time. So certainly, there's still more that we need to understand about this disease. Certainly, if you look at some of the symptoms, people describe newer symptoms post the acute infection, and really again, a body of work is needed to really help us understand and define this condition. If you just look at what are the risk factors, it's still really not known, but some of the literature would suggest that women, people who are obese, and older people may be at risk of having long COVID. But again, that's really anecdotal literature at the moment, given that there are very few people across the world looking at this, but various groups are beginning to understand that this is an important condition to look at and understand who is at risk and what puts you at risk of this. The immunopathogenesis, again, is still poorly understood for long COVID. You recognize that we're still also understanding or beginning to understand some of the pathophysiology of acute COVID-19, but certainly more needs to be done in terms of really looking at who is at risk and understanding the mechanisms at play for this. But this figure here just shows you some of the studies that have been done. This is some data that comes from Italy, just looking at some of the patients that they looked at in terms of after the acute episode of COVID, and just looked at what are some of the symptoms that remained post their COVID infection and post-hospitalization. And you can see that some of these symptoms include fatigue, certainly shortness of breath, and certainly cough persisting in some people. So certainly there are these symptoms that have been seen in people with COVID, and often persist for weeks after the infection. How long these persist for is still something that's really not known. But if you just look at some of the consequences, I think clinicians have recognized that there was going to be some long-term consequences from acute COVID-19. But I think given the kinds of activities we were dealing with in the acute phase of the pandemic, there was really little time to really look and study at some of these long-term consequences. But from a long perspective, I think there's been work or evidence emerging that certainly people hospitalized with COVID-19 will have pulmonary consequences. What we know or what we don't know is how long some of these will last. But we do know that the coronaviruses, certainly if you look at the last epidemic of SARS in 2003, a Chinese group looked at the long-term consequences of that and found and looked and followed up people for 15 years and found that some people, a minority of people, had long-lasting symptoms, even going as beyond as 15 years. And the question is that something we're going to see in people SARS-CoV-2, and certainly the evidence may suggest that yes, people are going to have long-term consequences. What we really don't know is how long those are going to last for. But just remember that there are also be consequences relating to some of the interventions that have been done for patients. Certainly, if you look at those who are in ICU and who have been intubated for long term, and the development of airway stenosis, certainly something that the European Society of ENT has alerted clinicians to be aware of as a potential long-term consequence of SARS-CoV-2, especially those who have been had airway interventions and recognize that there may be this group of people presenting to centers with airway stenosis. If you also look at the neurological system, we know that the neurological system can be affected by SARS-CoV-2, and certainly a feeling that there are going to be long-term consequences from this. And again, work and papers have been published just to alert healthcare workers of some of these long-term consequences. One of the ones that has come out is the issues relating to cognitive disability post COVID infection. Certainly, there have been patients who have described this brain fogginess as a symptom that lingers post the COVID-19 infection. Again, there's been recognition that some people are presenting with new onset seizures post the COVID infection. So certainly highlighting here that the neurological system is certainly not spared for some of these long-term consequences of COVID-19 too. And this is certainly data from the UK that suggests that people, even though people with mild disease of COVID-19 have had cognitive impairment or deficits, and suggests that even people with mild disease may have cognitive impairment, including, of course, those with severe disease. But some of the people that were interviewed in this were people who were not even hospitalized for COVID-19. The heart certainly has been also an organ that has not been spared by SARS-CoV, and a German study has reported sort of chronic manifestations of COVID-19 on the heart, and certainly there's been work that shows that there may be acute, obviously related COVID-19 infection that results in hospitalization, but again, a recognition that COVID-19 may also cause chronic effects on the heart, whether this is from a direct viral effect or an effect related to chronic inflammation. Is certainly what people are beginning to look at and begin to understand, and begin to also understand the impact this has on people who have survived an episode of COVID-19. So the question really is, why should physicians know about long COVID? Is there any treatment for it? And I think there's an important reason to know about it, because I think one, there's certainly a growing number of people who are certainly experiencing these chronic effects from COVID-19, and certainly need support from the healthcare system. But again, on the other hand, there are lots of things that we don't know. But as we have all recognized in this pandemic, is that things change very quickly and information comes to light also very quickly. So I think this paper really highlights some of the challenges that patients who are experiencing chronic symptoms from COVID-19 in terms of the challenges that they face. And really the message here is that one of the challenges they face is certainly having healthcare workers just understanding the challenges in terms of their symptoms, and certainly being empathetic towards them, but also just recognizing that these symptoms are real. In many instances, these patients will have symptoms without any physical manifestations of these symptoms, and really you need a healthcare system that is accessible to them, but also is able for them to access the healthcare related support that they will need. So certainly having healthcare workers understand that this is a real entity and that these patients need to be supported is quite critical. Of course, this then brings into light the infrastructure that may be needed to support these patients. What we don't know is how many of these people, or how many people who have or will get SARS-CoV-2 will progress to have these prolonged symptoms. And again, one also doesn't know for how long these symptoms last. So certainly there isn't in particular any particular treatments that are available for these patients, but certainly what is required is a multidisciplinary team to look after these patients. And certainly recognizing this disease entity is quite important, because you also don't want to over-investigate these patients as well, because that also has its own unintended consequences. Certainly, I think management of other underlying chronic diseases is important, but also, again, ensuring that patients get support to either a respiratory physician, psychologist, and physiotherapists, occupational therapists, to help them in the rehabilitation. If you look at some of the patients who describe some of the symptoms, people often describe the fatigue that makes it difficult for them to even get up in the morning, or even affects their ability to work. So this requires a team to really support patients in navigating their way through this. And as a result, in the UK, there are documents that are being developed to really try and give information both to healthcare workers and obviously those who are living with COVID, so that there is some sort of assistance afforded to these patients. Often the patients will tell you that they think it's just that they're the only ones who are experiencing this. But again, there has been this plethora of online support groups through Facebook and other social media, where patients are finding themselves and sharing their experiences. But of course, what's key is that we as healthcare workers need to ensure that we provide an infrastructure that helps and supports patients with long COVID, so that they continue really. It's just to highlight that we do need to understand long COVID. Certainly, there's still a lot that we don't know. Certainly don't know how long this condition lasts for. But I think it's important for healthcare workers who encounter patients to really believe that the patient's symptoms, especially when patients don't have any demonstrable physical abnormality. I think from a public health perspective, I think it's important that this group of people is sort of quantified, so that healthcare systems can be, healthcare healthcare systems can be able to better address them. We need to understand what infrastructure we need for these patients. And again, as they enter the healthcare facilities, who is going to be responsible for looking after them and certainly help them navigate their way through our healthcare system in terms of the resources that they will need. I think I'll stop there.
Right. Thanks very much, Sipho. That was a really useful overview of what we do know and what we don't know yet about long COVID, and so many unknowns in such a new entity. And it really strikes me that I'm sure as we get to know more about this condition, it'll become apparent that there's actually more than one condition, and probably many conditions with different etiologies and pathogenesis underlying them as they affect organ systems differently. But thanks very much for sketching out what is known. So we're going to look at the sequelae of COVID-19 from a different angle in our second talk. And Jackie Hoare will be addressing the topic psychological sequelae of COVID-19. Jackie is a professor and head of the Division of Consultation Liaison Psychiatry at UCT in Hoare in the Department of Psychiatry and Mental Health. She's also co-director of the UCT HIV Mental Health Unit. And her research interests are in mental illness, neurocognitive disorders, and adherence to medication in adolescents and adults with chronic illnesses. And Jackie and her team from Consultation Liaison Psychiatry were critical in the COVID-19 response at Hoare, providing much needed psychological and psychiatric support to patients admitted with COVID-19, as well as the healthcare workers looking after them. So really looking forward to your talk. Thanks very much, Jackie.
Thanks. Thanks very much to the organisers for this opportunity to discuss the psychological sequelae of COVID-19. COVID-19 has triggered anxiety, and measures to contain the virus have caused uncertainty, isolation, and economic despair, which have all taken their toll on mental health. Research indicates that people who have been affected by medical pandemics, such as survivors, caregivers, families, or health professionals, are more likely to experience psychological distress, sleep disorders, anxiety, and PTSD. At their worst, these symptoms can progress to suicidal ideation, substance abuse, and significantly reduced quality of life. Both the mainstream media as well as social media are increasingly reporting on the mental health consequences of testing positive for COVID-19. In addition, there are reports of survivors struggling with ongoing mental health issues, with multiple patients reporting that they were emotionally affected by their illness. However, the psychological consequences of COVID-19 extend far beyond those infected with SARS-CoV-2 and their families. In fact, the psychological consequences have been far-reaching and often devastating. Health professionals who have cared for these patients during this crisis are also vulnerable to psychological distress, particularly as population morbidity and deaths and the demand for health services increase. Unique stresses for health professionals include burnout and moral injury, which are exacerbated by shortages of medical supplies and health services during a time of unprecedented need. The rest of the talk will focus on patients who have survived or been infected with COVID-19. Both biological and environmental mechanisms have been implicated in emergent psychiatric conditions associated with SARS-CoV-2 infection. Social distancing, quarantining, and closing of businesses and schools have resulted in an unprecedented economic downfall. Environmental stresses augmented by psychological factors, such as loss of control, fear of death and dying, and isolation, are contributing to the emergence of psychiatric outcomes of the COVID-19 pandemic. Furthermore, coronaviruses may induce cognitive, emotional, neurovegetative, and behavioral dysregulation through biological mechanisms, including direct neuroinvasion and triggering of immune activation. Increasing evidence has linked immune activation with depression and suicidal behavior. The largest review published to date in the Lancet Psychiatry in July 2020, because of the paucity of the acute and almost no follow-up data from SARS-CoV-2, the authors developed a strategy to attempt to draw some conclusions from the previous coronavirus epidemics. They sought for published studies on SARS, MERS, and then SARS-CoV-2, but excluded studies that reported only on neurological disorders in the absence of mental health and psychiatric symptoms. The main findings from this review were that in the acute illness phase, any psychiatric or mental health symptom was present in about 63% of patients. I should just pause here and highlight that these are mental health symptoms that were reported and not mental health disorders. The most common symptoms included anxiety, impaired concentration, depressed mood, and emotional lability. Remember, these data include all three coronavirus epidemics. Looking at the post-illness data and follow-up, which ranged across the three pandemics from 30 days to 2 years, mood and anxiety symptoms, again not disorders, occurred in about 10 to 12% of patients. Neurocognitive symptoms were slightly more common at 18%, but the acute confusional states and delirium have subsided. The most common post-illness symptoms are fatigue, frequent recall of traumatic memories, and sleep disturbance. As this study was published in July, other studies have reported on both inpatient and outpatient mental health. I'd just like to go over a few studies which are more recent, which report that the majority of COVID-19 inpatients have experienced mental health disturbances. Disease duration, levels of inflammatory markers, and self-perceived illness severity were factors that predicted the severity of the patient's mental health symptoms. The main psychological dysfunctions included anxiety and fear. Most COVID-19 patients suffered from significant post-traumatic stress symptoms associated with COVID-19 prior to discharge. Again, this is symptoms, not post-traumatic stress disorder, where symptoms need to have at least 1 month duration and cause significant functional impairment. Patients with COVID-19 who had family members diagnosed with COVID-19 or died from COVID-19 were more susceptible to depression and anxiety than for other patients. And this was certainly our lived experience at Protoscare. In fact, a common reason for referral to me for therapy were patients who had already lost family members to COVID-19. Patients with COVID-19 showed significantly high prevalence of depression and anxiety. There's very little post-discharge mental health literature, but I'll run through that quickly. Most patients reported worse mental health 40 days post-COVID-19. 10% of COVID-19 survivors develop anxiety or depression because of post-discharge residual respiratory symptoms, worrying about recurrence and infection to others. Prevalence rate of clinically significant depressive, anxiety, and PTSD disorders for hospital discharge patients were respectively 19, 10, and 12%. Interestingly, survivors aged 60 or above experienced less stress response symptoms, fewer emotional symptoms of depression, and fewer anxiety symptoms than younger survivors. Our experience of dealing with the COVID-19 in patients were that it was very much in line with the findings in the literature that mental health symptoms and get-not disorders were very common in patients admitted to the wards, particularly those with severe COVID pneumonia. Symptoms were common, disorders were not. In the patients where I did diagnose a mental health or psychiatric disorder, the most common were panic attacks, acute stress disorder, adjustment disorder, depression, and delirium. Symptoms may not be disorders, but they can cause significant distress. Patient distress is not only a terrible personal experience for each individual patient, but also impacted frequently on patient management and decisions. I think of a few examples of what happened in the wards where patients became, for example, too fearful to be weaned off high-flow nasal oxygen, refusing transfer to another ward, either demanding discharge while still on high flow or refusing discharge, declining ventilation and transfer to ICU, and impacting on capacity to consent. This was my approach or algorithm for managing mental health symptoms in patients with COVID-19, and I've used this both within the inpatient and the outpatient setting. Inpatient setting obviously managed more of the acute distress and fear, and in an outpatient this was related more to symptoms of long COVID and evolving PTSD. So the first step was for me to determine whether the mental health symptoms were symptoms causing distress, or these symptoms were present but not causing distress, or whether the symptoms were numerous and constituted a mental health disorder or diagnosis of a psychiatric condition. In those where I diagnosed a mental health disorder or psychiatric condition, I considered antidepressant medication. The two most commonly used that I prescribe was citalopram, frequently because of other medical comorbidities, and mirtazapine because of the commonly reported disruption in sleep. I then selected from an array of brief therapeutic interventions which were really tailored to the patient. My three sort of favorites or go-tos in this population were either cognitive behavioral therapy, problem-solving therapy, or supportive psychotherapy. In patients where symptoms were present but not causing distress, I reverted to psychoeducation alone, which was really understanding what these symptoms were, putting them in context, and giving them tools and resources if, for example, the symptoms got worse and started causing distress. The vast majority of the work that I did, fell on the left-hand side, which were mental health symptoms, not mental health disorders, but these symptoms causing distress. And here I used psychological first aid and relaxation techniques. So what is psychological first aid? Psychological first aid has been recommended by many international expert groups, including the Interagency Standing Committee. The World Health Organization evaluated the evidence for psychological first aid and psychological debriefing. They concluded that psychological first aid, rather than psychological debriefing, should be offered to people in severe distress after recently exposed to a traumatic event. Psychological first aid is not psychotherapy, and psychological first aid is not an intervention that is confined to mental health practitioners. It's very basic. It consists of providing practical care and support, assessing individual patients' needs and concerns, helping them to address basic needs such as access to information, listening, but not pressuring them to talk, comforting people, helping them to feel calm. And in the context of COVID, I realized feeling safe was also a significant part of how effective I was able to be in terms of connecting with a patient therapeutically. Helping people to connect to information and social supports, and in the inpatient context, this involved a lot of WhatsApp video calls. The IASC has actually produced some basic psychosocial skills as a guide for COVID-19 responders. These skills assist persons working with COVID-19 patients in everyday communication interactions. They provide a set of tips and guidelines on how you can present yourself in everyday interactions, such as the tone of your voice, posture, and how these things can affect people. I know that many people working with COVID patients aren't mental health practitioners and frequently worry about having to sort of deliver some kind of comprehensive psychosocial support. These are interventions that can take place in a very short period of time. In actual fact, it was a bit of a strange experience for me, but often via social media like Facebook and WhatsApp, etc., there were patients talking about the interventions that I gave them while they were admitted to critical care. And many of the things they said were things like, it was only 10 minutes, but it made all the difference. Or she spoke to me for 5 minutes and I felt better. These aren't psychosocial first aid, it's not comprehensive therapy, and they're tiny little things that you can do in every single time you interact with patients. They encourage practitioners to give the patient your undivided attention, truly hearing their concerns with care and showing respect and empathy. If we can make a patient feel safe, a patient really is able to listen and cooperate with all kinds of medical interventions and care far more effectively than if they're afraid and distressed. So really, with listening attentively, repeating what the patient had said, just to reinforce to the patient that I had heard them, summarizing that I had understood them, really allowed me to access patients, help them to feel safe and secure very quickly in a high-pressured environment where I didn't have the luxury of a 45-minute or an hour psychotherapy session. Once patients felt safe, it really resolved many of the issues that came up in patient management, such as refusing discharge, refusing to be weaned off high flow, or not wanting to be transferred to another ward. The relaxation techniques I frequently used within the high care units was this breathing exercise. I have to say, though, that I did learn very quickly that this breathing exercise was not for everyone. My recommendation is that this shouldn't be tried with somebody who isn't able to maintain SATs on supportive oxygen of more than 90% at rest. The way this worked was it was providing patients with some kind of agency or self-control or tool where they were able to manipulate their SATs as they were using SATs monitors. If they used this breathing technique, I also combined this with some mindfulness or meditation strategies. They were able to observe their SATs improving. This didn't, however, work with patients with brittle COVID pneumonia who weren't able to maintain SATs of at least 90% at rest. So I avoided that exercise in that group of patients and went rather for the kind of mindfulness or meditation techniques without using the breathing exercise. And that is it, other than just to thank the incredible colleagues that I worked with at critical care during this very traumatic time.
Thanks very much, Jackie. That was really a great overview, picking up on both what's been published in the literature and your personal experience. So we've got some time for discussion and questions. If people in the audience wish to pose questions, then just type them into the chat, and Mark will relay those to the audience. Jackie, perhaps if I could ask the first question, just if one looks outside the context of COVID-19 and looks at what's been published in terms of the benefits of these kind of brief interventions in other traumatic situations that people have been in, and is there much data to show that they can prevent long-term psychiatric conditions like generalized anxiety or PTSD, even with a kind of modest brief intervention?
Yes, thanks for the question, Graham. And yes, this is why the WHO are supporting this kind of psychological first aid. It's about giving patients a sense of control and a sense of safety after a very difficult time. So this isn't the sort of psychodynamic debriefing of traumas, which used to be the kind of old practice, which, at its worst, actually may have made outcomes slightly worse. This is just about helping or assisting a patient to feel sort of contained and slightly empowered after an incredibly difficult time, so that there's not a sense of absolute feeling out of control and helplessness. So my sense was while I was mostly treating symptoms and not disorders, was to use basic techniques which were evidence-based, particularly evidence-based in other trauma contexts, which can prevent, we hope, certainly it has been in other trauma contexts, further mental health issues downstream.
Great, thanks. So, Sipho, I just wanted to bring Ntobeko Ntuzi, as everybody knows, Ntobeko is our head of medicine, in and see if he wanted to make any comments regarding long COVID from the angle of the cardiovascular system. Mark, are you able to unmute Ntobeko?
Yes, he's done.
Okay. Ntobeko, did you want to make one or two comments, and if there are any sort of discussion points that you want to bring up with Sipho?
No, indeed. Thank you very much, Graham. So we know that COVID-19 is primarily a respiratory illness, but cardiovascular involvement is common and occurs via a multiplicity of mechanisms. These may either be direct mechanisms due to direct viral infection of the myocardium, and this is demonstrated on endomyocardial biopsy, or there may be indirect mechanisms as a consequence of thrombotic occlusion of the coronaries, ischemia, myocarditis, Takotsubo, and even cardiotoxicity from the drugs we use to treat cardiovascular disease, which may cause QT prolongation, a drug-induced myopathy and myocarditis, or different arrhythmic events. And in fact, as an advertorial, we've got a whole issue of the South African Heart Journal, one of the journals I edit, with 16 articles focusing on COVID-19 cardiovascular disease. And Jackie Hoare is an author on one of those articles, and I would recommend people to review that issue of the journal. And in terms of the clinical manifestations of cardiovascular disease, these are typically, in no order, acute elevations in blood pressure or new diagnosis of hypertension, acute cardiac injury, which is defined as an elevation of cardiac troponins reported in up to 12% of patients, acute coronary syndromes, acute left ventricular dysfunction, heart failure is very common, and in fact, arrhythmias, both supraventricular and ventricular tachycardias, may be a presenting feature of COVID-19, and we've seen many cases of cardiomyopathy due to COVID-19. There is also an emerging body of evidence linking lasting cardiovascular complications to COVID-19, what we call cardiovascular long COVID. And these include persisting left ventricular dysfunction, where it didn't exist before, chronic heart failure, on imaging evidence of chronic myocardial edema, which is associated with cardiovascular symptoms, patients with symptomatic arrhythmias that didn't exist before they had COVID, and premature cardiovascular mortality. And as a final comment, I think it's worth highlighting mechanistically the bidirectional relationship of cause and effect between cardiovascular disease and COVID-19. So on the one hand, COVID-19 causes myocardial injury, heart failure, thromboembolism, Takotsubo, myocarditis, all of which can have severe consequences for patients. But on the other hand, cardiovascular disease, particularly in the form of hypertension, diabetes, coronary artery disease, and heart failure, increased susceptibility to SARS-CoV-2 infections, but in those who do acquire the infections, also increase the risk of much more severe phenotypes. So I'll stop there, perhaps to make a comment for Jackie to say that I've not been familiar with the concept of psychological first aid before, but it's very compelling and attractive, and something I think we can use in many more settings, even outside of COVID. And from the way you describe it, I suspect one may not even need to be a psychiatrist to be able to apply some of its core tenets. Thank you so much, Graham.
Graham, just unmute.
Thanks, Mark. Sipho, anything you wanted to pick up on?
Yeah, no, look, I think the important thing is the message I wanted to make is that, first of all, I think this is a recognized clinical entity. We need to recognize it because it's kind of been also labeled as anecdotal, and that is problematic when it comes to it being taken seriously and effective communication. So I think the recognition that this is a real entity is important, because we need to quantify it and probably accurately describe it as well, because it does have implications. You can imagine the implications are not just only to the individual patient themselves, but also has sort of economic and obviously psychological consequences. And these are important because some of these people will need to be supported. So if employers don't recognize, the chronic fatigue that someone may experience post-COVID, there becomes a challenge in terms of how then do you reintroduce them back to the workplace and economic activity. And I think this is quite important when you talk about a young country as ourselves, where you're going to have a lot of young, economically active people who may experience long COVID. And we really need to understand how many of those people are going to experience that. So what is the risk of that happening? And then build the infrastructure that may be needed for that.
Thanks, Sipho. So I just want to, I see Kirtan Dada, the head of pulmonology, has typed a question in the chat function. But I just wondered if we could draw in Kirtan, and so both to ask that question about, do we see similar syndromes with other common infectious diseases? But secondly, I'd also like Kirtan to comment about whether, the pulmonologists have been seeing in our setting, the long-term consequences of lung damage, particularly in those patients who've been admitted to ICU with COVID pneumonias.
Thanks, Graham. Can you hear me?
Yeah, I can hear you.
Yeah. So thanks, and thanks for the very informative talks. And as has been pointed out, we are learning and we know very little about post-COVID. But I think the first thing to say is that we know very little about chronic lung symptoms after severe respiratory infections. For example, with TB, as you would know, Graham, there's hardly any information, about a lung disease that kills almost somewhere between, 1.2 and 1.5 million people a year. We don't even know the natural history. There's not a single good long-term prospective study about the natural history of post-TB lung disease. And I recently had the opportunity to look up influenza. And, there's another disease, despite a lung disease, despite killing probably 600,000 or 700,000 people a year. I couldn't find a single good paper, looking at the long-term lung sequelae of influenza. So I think this is something that we really need to look into. And I guess what my question brings up, and maybe Sipho and the others can comment, is I think it's very important to have control groups. Is long COVID or the symptoms associated with it any different from any other severe acute respiratory infection or other infectious disease? The second point I wanted to make was, and I suppose in connection with the first one, is there's a lot of literature emerging, I see even in the latest issue of Lancet Respiratory Medicine, changing paradigms as we learn more. So for example, the cytokine storm syndrome or leukocyte activation syndrome, whatever you want to call it, now that we have control groups, so, other groups with other causes of ARDS and sepsis. So for example, IL-6 and TNF levels are much higher with other causes of sepsis and other causes of ARDS than COVID-19. So, we initially thought, wow, this must be a very important part of the syndrome. And as more data is emerging, the paradigm is shifting. So I think it'd be interesting to see what we find. The lung disease part is quite complex because I think it's going to be dependent on pre-existing lung disease, the severity of COVID-19 pneumonia, and of course, age and comorbidities. We know from community-acquired pneumonias of any cause, the older the age, the more severe the chronic sequelae of the disease. So, and of course, related to that is, genetic background, the infecting dose of the organism. So I think it's gonna, there are many threads to this and it's going to be quite complex. With regard to the respiratory service, we have started a post-COVID, long COVID clinic, and that's run by Rubeshan Perumal together with other people in the respiratory clinic. He's sort of spearheading the whole effort. I know that we are dealing with several other, or talking to several other stakeholders to provide input into that clinic, but that clinic is active. I think we have circulated the referral pathway to that clinic, and we welcome other people to give input into that clinic, and I can try and recirculate, the referral criteria and the way in which patients can be referred to that clinic. Thank you.
Thanks very much, Ketan. Sipho, anything you wanted to pick up on there?
No, I think Ketan is right. I think control groups are really important, really to get us to understand exactly what is going on. I think just to mention that we have recognized other viral infections causing prolonged symptoms. So if colleagues remember the Ebola, certainly what happened after addressing the Ebola crisis in West Africa and Central and East Africa is that some of the research teams remained behind just to follow up patients from on a long-term basis. And certainly the research showed that people did experience chronic symptoms after surviving Ebola. And certainly also what we learned that the Ebola people shared virus from certain compartments for even quite a long time after getting better from that illness. So certainly following patients up for a long time is important because we do learn things about some of these viral infections. So Ebola is just one in the reunion a couple of years ago, following a chikungunya outbreak. The chronic fatigue and arthritis was something that people recognized in that island and are still grappling with. So there are viruses that we do know cause these chronic symptoms after people have survived the acute episode, and I think SARS-CoV-2 is no different to that. I think the difficulty here is that this virus affects a multitude of organs. So it's just not only the respiratory tract, there are other organs, and we just don't understand how those organ systems either are impacted from that episode, whether it's a direct viral mechanism or inflammation-driven mechanism are things we really need to understand so that we can put in either the correct therapeutics for them if need be.
Yeah, thanks, Sipho. I mean, I think there's partly an impact of the epidemiology here. When you've got a low-grade endemic infection and 5% of people are developing, 5 to 10% of people are developing complications, it might go under the radar. But when it's a pandemic and everybody's developing this, 5 to 10% are developing the post-infectious syndrome simultaneously, it suddenly becomes far more impactful on the health services, and people wake up to that. So I think let's just deal with the last comment, Mark, that's been typed in the chat function, and I might ask Sipho and then Tobacco to comment on that, and then we could wrap up after that.
Graham, there are a few other questions that I can deal with if we have some time. So, Sipho, the question related from one of our sports physician colleagues, Dr. Lee Gordon, saying, and I saw this comment from another viewer as well, obviously dealing with fairly fit individuals who are experiencing, sports people, elite athletes, who are experiencing post-COVID exercise intolerance. This is being observed. I mean, anybody seeing something similar? Any comments to make? Maybe to yourself and Tobacco, as Graham indicated.
No, thanks, Mark. I think all I can say is that certainly, the descriptions from what one has seen from the literature in terms of people going back to their previous physical performance status varies across survivors of COVID-19. The issue of tachycardia as a persisting symptom has certainly been noted, and the real issue here is the difficulty in terms of saying when people will actually go back to their normal physical state. Is a very difficult thing to say because there's a lot we just don't understand, and certainly what has emerged is that people go through cycles. So you go through cycles of feeling very well, and then the following week you're back to what you were 3 weeks ago. So people are going through these cycles, and we really just don't know how long some of these symptoms will persist. So that's why it's important that people are followed up and monitored to see exactly whether some of these are long-lasting or just transient manifestations of post-COVID.
Perhaps I can just make a very brief comment that the persisting tachycardia and impairment in exercise tolerance was recognized from the early days of COVID-19. And people have looked at the natural history, and it seems to persist for about 6 weeks before it comes down. And it's also clearly linked to levels of markers of cardiac injury. So if you look at the serum troponins and on imaging evidence of persisting myocardial inflammation. And as a consequence, there are now a number of guidelines from a number of societies suggesting that people who've had COVID probably shouldn't take up exercise for 6 weeks following end of symptoms. And the persistence of myocardial inflammation may be a marker that portends poorer outcomes if people take up exercise early. There have been historic studies showing that if people start exercising vigorously with active myocardial inflammation, the rate of conversion to a dilated cardiomyopathy is much higher than if you allow people to recover fully before they start taking up exercise.
Graham, there are quite a few practical questions here, which I'm going to direct to Jackie. There have been a number of people from various quarters just asking a general question. The one is about referral pathways for patients with psychiatric and mental health issues post-COVID, and then also for healthcare workers and affected individuals and family members. What are the referral pathways available, Jackie?
Thanks. So with Hoare patients, it's referral to the Department of Psychiatry. I have to add a little note to that, though, that psychiatric services are heaving, and this is one of the consequences of COVID-19. First of all, in reducing services during the first wave, as well as I think many mental health care users struggling to access services during this time, and I think there are many folks out there who may have been sort of teetering on the brink of mental health symptoms now becoming mental health disorders. So our services are absolutely bursting at the seams, not just with COVID survivors, but with just a general population of mental health care users. We are on Rula. So you're welcome to make a referral in that way, or email me, or send the referral straight to J2, our outpatient department. In terms of healthcare workers, we actually developed quite an extensive response, mental health response for healthcare workers at Hoare Hospital. And this was done as in combination with Metropolitan Health, which has a contract with the Department of Health for providing training and mental health care in the Western Cape. We worked quite closely with them to make sure that they delivered care that was useful and meaningful. We also had an occupational therapist who usually works in mental health, who became sort of go-between between Metropolitan Health and healthcare workers. Accessing psychological support still carries a lot of stigma, and we found that if healthcare workers knew somebody on the ground that they could trust and feel comfortable and safe with, if that person facilitated the referral to Metropolitan Health, then things went a lot smoother. In addition to that, Louise Frankel and I ran a series of support groups for many different departments. Those have stopped now due to the pressures on the psychiatric services. I would like to think, or I do believe, that doctors and nurses really benefited from those groups. What we have learned is that there is a lot of power in teams, and to be able to get together and talk about shared experiences and shared trauma increases that kind of sense of belonging and cohesion between teams. So that was a really important process. Louise and I were then also available for individuals who were in crisis and didn't feel that they could access Metropolitan Health or wanted to access Metropolitan Health. What we did under those circumstances was provide a once-off, I suppose, screening or assessment appointment to understand just how severe or how urgent the situation was, and then facilitate referral to longer-term care thereafter, which was obviously very different for folks who are on medical aid and those who weren't. Just as a note, though, for even if you're on a hospital plan on medical aid, if you develop depressive and anxiety symptoms, that you are able to access via PMB 15 sessions per annum. So that's very useful to know that even hospital plan folks can access 15 sessions with a mental health professional, which is can be a combination of psychiatry, psychology, or one or the other. So that's a mechanism that we used a lot of. There were some great private colleagues out there who were on standby for Louise and I to contact for emergency appointments for healthcare workers.
Thank you, Jacob. Thank you. Graham, I've left off with probably 3 of the most challenging questions of the afternoon if you have time. You saw me post them up. I'm not sure we have enough time left to answer them, but they were fairly challenging. And you saw them.
I see, Mark. I mean, I think they speak to, from Max Price and Ashraf Grimwood, the question of what are the mechanisms of the fatigue, as well as, more generally, what is the pathogenesis of this condition. I mean, Sipho, did you want to say anything? I've got 1 or 2 comments as well, but you go first.
Yeah, no, thanks, Rem. Yes, I think the first one just from Max Price about the pathophysiology of the fatigue. I think I just want to remind colleagues of the chronic fatigue syndrome, because this is almost similar to that. And for decades as a medical fraternity, we have struggled to really define this disease. I think with chronic fatigue, we all know that there are no biomarkers for it, but certainly people have symptoms, and we recognize it as a disease entity. And I think with the fatigue that people are experiencing with COVID-19, we may not get a biomarker for it. And we have to appreciate that there's still very little we understand about how these mechanisms arrive at people experiencing this fatigue. And the question of whether it's direct virus or the immune system, one can only speculate, but I think it's just fair to say to people that this is a real clinical entity, and we may not necessarily come to have biomarkers to make that diagnosis, but really support people who experience this fatigue. I think that's quite important. I think the other question about virus shedding, to be clear, is that we just don't know. I think some scholars think that virus shedding may be an explanation for why we've got people with long COVID, but I think there is no evidence to demonstrate that. That must just be clear. So, so there are other postulates about an immune mechanism, whether the virus triggers a dysregulated immune system, and that's why you get people with these long symptoms is another postulate. So there are many postulates out there, but none with vigorous scientific evidence for them.
Yeah, thanks, Sipho. I mean, just to really add to that, I think on the issue of the fatigue, as I said after Sipho's talk, I think this is a very heterogeneous conditions and there are multiple mechanisms. And so if one's sort of encountering a patient with fatigue, I think the first thing you would ask is has this person had severe pulmonary disease, and could it be explained by lung damage or pulmonary thromboembolic disease, and investigate for that. But I think, the minority of these people would actually have SATs, either at rest or on exertion. And then secondly, you would ask, along the lines of what Ntobeko was discussing, could this represent ongoing myocardial injury and inflammation, and look at the biomarkers of cardiac injury and perhaps some imaging if there was clinical suggestion of that. But I think that probably explains the minority of cases, and then look at whether there's ongoing inflammation. There hasn't been, as Sipho said, evidence that the inflammatory markers are elevated in this phase of the disease. But it could be something that accounts for some of those. And I think probably a lot of it is centrally driven fatigue. And then with some neuropsychological aspects that Jackie was referring to. So there's an interplay between the organic and the neuropsychological, and I think that might account for some of that. But in different people, I think there are going to be different processes going on. And then just generally on the issue the pathogenesis, it's, it's thought, does it represent ongoing viral replication? Does it represent an immune response, a long-term chronic inflammation, or does it represent injury to tissue like the myocardium or the skeletal muscle? And, we don't have the answers to that, but as Sipho said, I've not seen any evidence that people who have longer viral shedding are more at risk of long COVID. And I think that's the hypothesis with the least support, is that it represents ongoing viral replication. I think, a tissue damage and inflammation are the most likely, and then central mechanisms. So on that point, I think we'll wrap up. And just to say,
Graham, Jackie just had a quick wrap-up comment to make.
Go for it, Jackie.
Sorry, I just want to point out that many of the symptoms of long COVID also cross over with mental health symptoms. It's not to say that they are mental health symptoms, but I think it's important to exclude a mental health condition, particularly a symptom such as fatigue is particularly common in depression as well as PTSD. And if the emerging literature is anything to go by, is that both of these conditions are likely to be common post-COVID, particularly those who were admitted to hospital with severe COVID pneumonia and who were admitted to ICU. But then there's also the kind of collective trauma that we are experiencing, and it is ongoing. You only have to turn on your television and immerse yourself in social media for a very short period of time. Certainly my anxiety levels raised pretty quickly, and one of the sort of mental health tips is try and limit your time with both mainstream media and social media. But I think that this collective trauma is driving the fear around COVID. Particularly in the inpatient wards, fear was almost palpable. It literally felt like I was walking into an environment that was humming, not just with the machines going, but with dilated pupils and hyperventilation. The fear is real, and folks are still afraid, perhaps not afraid enough to actually not go to parties and wear a mask, but people are afraid. The other last thing is that we, as psychiatrists, we do deal with patients who have chronic fatigue syndrome. And I would just ask everybody to be mindful of the language that is used when dealing with patients with long COVID. These experiences are all real, they're not hallucinations. So the kind of idea that it's all in your head or you're making it up is exceptionally unhelpful. And what we find with patients with not only chronic fatigue or with chronic pain, where there's no biomarker or there's no identifiable underlying cause, these experiences are real, however unexplained, are real. And I think we will do our patients a lot of harm by not holding on to those ideas. So again, the psychological first aid principles might help in the context of chronic fatigue. Undivided attention, making somebody feel that they've heard, repeating what they've said, summarizing what they've said, and empathizing with them will go a long way in terms of containing somebody whose anxiety must be incredibly high, given the fact that we don't really know what this means, what long haul COVID means, or, this is new to us and it's new to everybody else out there. Thanks.
Thanks, Jackie, for that sort of reminder of keeping a very holistic approach to these patients. So just to wrap up then, to say thank you very much to Marianne, to Sipho, and to Jackie for three excellent talks, and then to Ntobeko and Kirtan for joining in the discussion. It's been a really excellent overview, a very important topic, and I'm sure in a year's time we could come back and have this session again, and we'll have far greater insights into this condition. And to the audience, just to say that our last ECHO webinar for the year will be next week, and we'll be looking at a summary of the evidence regarding the treatment of COVID-19 to be given by Sean Wasserman and Linda Boloko from the Department of Medicine. So thanks very much, Mark and Wendy and everyone.